Hello, my name is Quentin Broussard. I am an assistant professor of clinical sciences at Keck Graduate Institute. Today we will be discussing nutrition support, including enteral nutrition as well as parenteral nutrition. Our objectives for today are to assess nutrition status and nutrition requirements based on patient parameters, to describe components of both enteral nutrition and parenteral nutrition and how they may be similar and how they may be different, to identify reasons or indications for patients to be on enteral and parenteral nutrition, to classify enteral and parenteral nutrition access routes, to recognize complications of enteral and parenteral nutrition, to discuss drug-nutrient interactions and compatibility issues associated with enteral and parenteral nutrition, and then additionally to prescribe appropriate parenteral nutrition formulas, which we will do on the parenteral nutrition prescribing day. We're going to start off with a patient case. AF is a 42-year-old male. He's 5'7" and 65 kilos. He presents to the emergency department with sepsis as a result of pneumonia. So sepsis is a type of lethal infection. He was subsequently intubated, so they basically placed a breathing tube down his throat, and they transferred him to the intensive care unit for closer monitoring. A central line and a nasogastric tube or an NG tube were placed in the ICU. The patient currently has a functional GI tract and is currently not on vasopressor therapy. After doing a nutritional assessment, the patient does not appear malnourished. So the first question is, based on weight-based equations, what is the patient's calorie requirements? 15 to 20 kilocalories per kilo actual body weight daily, 20 to 25 kilocalories per kilo actual body weight daily, 25 to 30 kilocalories per kilo actual body weight daily, or greater than 30 kilocalories per kilo actual body weight daily. Which type of nutrition is most appropriate for the patient to receive? Oral nutrition, enteral nutrition via a mechanism such as tube feeding, peripheral parenteral nutrition or PPN, or central parenteral nutrition CPN. And what is the most likely complication of the type of feeding selected in case question 2? Abdominal distension, hypokalemia, metabolic bone disease, or PN-associated liver disease, or PNALD. So after today's lecture, you should be able to answer each of these questions confidently. The first thing we're going to talk about in terms of nutrition is nutrition assessment. And whenever we're doing nutrition assessment really is broken down more or less into two components, the nutrition screening and the nutrition assessment components. And these are important for determining the care of the patient in regards to what type of nutrition that the patient is going to need and how much. And our goal whenever we are doing a nutrition assessment or a nutrition screening is to identify nutrition risk or malnutrition. So typically what screening is we're basically looking at a few different set parameters of the patient to see if they have any risk or identifying features that they actually can be considered malnourished or have a diagnosis of malnutrition. The assessment kind of goes a little bit deeper than the traditional screening process, where we actually are doing a little bit more in-depth type of assessment of the patient. And whenever we assess the patient, we're actually looking more comprehensively at the patient. So we're looking at different components of the patient's history. So we're looking at things like history and diagnosis. So what past medical history might the patient have? What current diagnoses do they have? Do any of these actually influence the patient's ability to eat? Do any of these disease states increase energy expenditure, for example? So if a patient has certain types of infection, they may actually be in a more what we call stressed state, and that might actually require them to burn more energy to basically make up for that stressed state. We also look at other things, so things like physical exam. Has a patient lost or gained any weight recently? Has a patient had any other types of inflammatory responses? And inflammation is a really, really big thing whenever we're assessing nutritional status, because inflammation can actually affect the way that different nutrients are metabolized and used by the body. Additionally, it also plays a role whenever we are interpreting certain labs. For example, if a patient does have inflammation, which can be related to a disease state, particularly whenever a patient has, like, for example, an elevated C-reactive protein, we might actually use other lab parameters like albumin and prealbumin to typically assess or get an idea of a patient's nutritional status. If a patient has an elevated CRP level, for example, that albumin and prealbumin that we might use to assess nutritional status might not necessarily be accurate. And that's why inflammation is important. Inflammation is important in terms of our interpretation of our lab parameters, but inflammation can also affect the body habitus also. Certain types of inflammation may cause a patient eventually to have edema, for example. And remember, edema is basically fluid collection in certain parts of the body. And whenever you have edema, that can actually affect the patient's weight. It affects the patient's weight, and as a result of affecting the patient's weight, that might actually affect how much we actually feed the patient, because as you saw in the introduction questions, some of the calorie parameters that we actually use to measure out calories for patient are based on patients' weights. We might look at things like anthropometric data, so patients' height, weight. They have different skin folds or circumferences around their body, like, their body waist, for example. These are not always going to be hard and fast, the most accurate parameters to get an idea of whether or not a patient has a diagnosis of malnutrition, but they are important for us in just our overall general assessment of the patient, and sometimes to deliver our nutrients appropriately, because, again, we might have to calculate these. We might have laboratory information that might be important, as we mentioned before, serum albumin, prealbumin, and CRP. Dietary data. If patients haven't been eating recently, they may be more at risk for a diagnosis of malnutrition. Alternatively, patients may have been eating very much prior to a stay in the hospital or to a clinic visit. So we have to take that into account as well whenever we determine how much feeding we're going to feed a patient. We also want to take into things functional performance. So things like activities of daily living, strength and physical performance are very, very important whenever we're taking a look at a nutrition assessment. Can the patient walk? Do they walk well? Do they have adequate hand grip strength where they can actually, grasp things appropriately? And it might sound, relatively normal to have normal hand grip strength, but for some people that actually is a struggle for some people. And that can actually be a surrogate marker for poor nutritional status if the patient doesn't have, for example, like adequate hand grip strength. So whenever we're looking at potential malnutrition diagnosis, we're actually looking at a lot of different things. So we're going to focus on a few different things on this slide, such as weight loss, energy intake, and BMI. But keep in mind that there are many different factors that we need to consider whenever we're actually making a diagnosis of malnutrition. And also keep in mind that, we're not only just feeding patients who are malnourished. A patient who is malnourished may be more predisposed, for example, to get nutrition earlier rather than later. But we need to have an idea of who our higher risk patients are. So as we mentioned before, weight loss and energy intake are significant factors, and the factors parameters specific to those factors that are boxed in red are the ones that I really want you to know, because these are going to be indicative of a malnutrition diagnosis. So, for example, if a patient has a recent history of weight loss, for example, greater than 5% over 1 month, 7.5% over 3 months, 10% over 6 months, or 20% in a year, that's very significant. especially if this weight loss is unintentional. If this weight loss, for example, is intentional, like say if a patient is actively trying to lose weight, for example, it might not necessarily always be a diagnosis of malnutrition, unless the patient purposely is not eating and getting enough of their actual caloric and nutrient intake. So those are other things that we have to take into account with these percentages here. But if the patient is doing something that is unintentional and they're losing weight, then in those cases, this might be a malnutrition diagnosis by having any one of these factors. An energy intake less than 50% over 5 days or less than 75% over 1 month. So if a patient isn't taking in diet adequately, that could be a problem. So say if the patient's normal diet is 2,000 calories and they're taking in 50% or less of their calorie requirements, so that would be less than 1,000 calories, for example, over 5 days, you can technically consider that patient to potentially have malnutrition. In addition, BMI is also another big consideration. So we consider a BMI of less than 18.5 to be underweight. And sometimes patients might be underweight just because of the way that their body is built. It doesn't necessarily always mean a diagnosis of malnutrition. It just might be, the way that their genetics go, and that's perfectly okay. On the flip side of things, patients might be obese, but they might not necessarily have too much fat habitus on them. They might not necessarily have excessive amounts of body fat, for example. They might actually be made up of more muscle. And usually whenever I think of these types of people, I think more of like bodybuilders and power lifters and people like that who may have a higher weight compared to their height. And it's not necessarily always a bad thing. It just, per the BMI parameter, puts them into a certain BMI classification. The thing I want you to know here with these BMI classifications, not only do I want you to know where each BMI falls in terms of its classification, I want you to realize that if a patient's BMI is less than 18.5, it's almost kind of like a yellow flag, more or less, to determine whether or not the patient has malnutrition or not. Keep in mind that malnutrition has many factors to consider, that second bullet point there, many factors to consider. It's not just going to be one thing or another that a patient may have. You need to have multiple parameters to be considered malnutrition. And whenever I say multiple parameters, I'm not just referring to these parameters that are on this slide, but additionally, they may have other disease states, which we'll talk about a little bit shortly, to basically put them in a malnutrition category. And here are some of those actual disease states that might predispose a patient to actually have a diagnosis of malnutrition. So whenever we think malnutrition, usually we want to think, BMI, energy intake, and weight loss history. But we also want to, try to correlate that and see if it has to do anything with their disease states. So whenever we're taking a look at the different disease states and conditions that a patient may have, some of these might be disease states. Some of these might be actual social or environmental circumstances. We want to make sure that, if a patient has a reversible cause, that obviously we are treating that reversible cause that caused their malnutrition or is related to their malnutrition. So one thing that I typically think of whenever I think of malnutrition is oncology, malignancy, and cancer, more or less, because those patients tend to have different bodily processes that are going on in terms of being very inflammatory. And a lot of those inflammatory mediators can actually influence our ability to want to eat. In addition, we have other different medications out there like chemotherapy, for example, and other different treatment modalities like radiation or surgery that may, in some effect, either may make the patient not want to eat, may hinder a patient's ability to eat. They might have taste disturbances, for example, from certain types of treatments, and that may actually hinder their ability to eat and gain weight or maintain weight. So whenever we are thinking of patients with malnutrition, we want to think of other types of disease states that exist. Another big thing is basically patients with psychiatric disorders. If a patient, has, for example, depression, they may be more prone to, having potentially an eating disorder, for example. It's not necessarily hard and fast, but sometimes they may not be able to eat in the same way that a normal person would eat. So we have to keep all of these different things in mind. So these are classified into acute, chronic, and social and environmental circumstances. I just want you to kind of get a flavor of all of the different things that can be related to malnutrition. I'm not going to ask you specifically which one of these disease states would cause a diagnosis or be related to a diagnosis of malnutrition, but I do want you to kind of think through some of these, especially the ones that you have already learned about, and go from there and kind of understanding the patient more holistically. So whenever we are, doing our general assessment of a patient, we want to estimate what their energy expenditure is. And this is consisting of things like basal energy expenditure, or BEE. That's the energy expenditure that a patient normally gives off every day. A patient may also have diet-induced thermogenesis, which is about 10% of their actual total energy expenditure. So whenever a patient eats, for example, they are going to burn some of that off immediately when the diet is actually taken into the body. And additionally, we have energy that is used for physical activity. So that's not just things like, standard exercise. That might be, things like, doing your normal activities of daily living, walking, moving around a little bit, not necessarily where you would consider it, part of your exercise regimen, but we do need energy for physical activity. Whenever you have a patient who is sick or injured, or particularly hospitalized, sometimes those requirements in those types of patients will go up in a lot of cases. And it's not always hard and fast which patients it will go up in. And we'll go over that in just a moment. But I just want you to keep in mind, if you're sick, your metabolism starts to basically speed up. And with that metabolism speed up, that might increase your caloric needs, and it might increase your protein needs. We assess energy expenditure in many different ways. We do these primarily and most commonly through weight-based equations, which are the most commonly used, which we will be using throughout this class. Predictive equations, which are not as commonly used, but they are still relevant, and you've probably actually heard of a few of them. And indirect calorimetry, which is actually what we consider the gold standard. And the picture on the right here is actually a picture of the machine, the indirect calorimeter, that performs indirect calorimetry. What this machine actually does is it measures the intake of oxygen into a patient and the expulsion of carbon dioxide, just normal breathing processes. And keep in mind that our macronutrients are built up of different organic molecules. So keep in mind that organic molecules are things that contain carbon, oxygen, hydrogen. So whenever we breathe off CO2, for example, that CO2 is actually a byproduct of the breakdown of all of the foods that you eat. So we take oxygen in and we actually expel CO2 out. So whenever we're taking that oxygen in and expelling that CO2 out, that CO2 is actually a byproduct of our own metabolism. Even though it is being exchanged at the level of the red blood cell, at some point that CO2 within another form, and most likely associated with a macronutrient of some type, like protein, carbohydrate, or fat. And whenever we actually expel that CO2, that's actually a surrogate measure for how much energy we're actually expelling, or basically our total energy expenditure. And indirect calorimetry measures this. The patient's usually hooked up to this machine for about 30 minutes to an hour, and it basically is trying to measure the patient's energy expenditure. And that's actually how you can get the most accurate measurement of a patient's energy expenditure. Keep in mind that these machines, anytime you have technology involved, are very expensive, so these aren't used very often. However, they will give you the most accurate reading, and that is why it is considered the gold standard. We have many different equations that we use for the purpose of calculating caloric requirements. So we have weight-based equations primarily that will measure those requirements. So everything that you see in bold here, you need to know for exam purposes. What I do want to emphasize here is that normal, healthy patients have a wider range of calorie requirements that they may need per day. And it may range in the frequency of 20 to 30 kilocalories per kilo actual body weight per day. So these are healthy, normal nutrition status, and minimal illness severity patients. So these are patients that you might see, traditionally on the outpatient end, or you might even see them still in the hospital, but on a general ward or general floor area, not necessarily in the intensive care unit, where they may be even sicker and metabolically stressed. So that basically applies to our healthy, normal nutrition patients who are not critically ill, not ICU. The next three rows actually apply to patients who are in the intensive care unit or ICU, also known as critical care. So if you have a patient who is metabolically stressed so much in the critical care unit, and their BMI is less than 30, they will actually get they will get 25 to 30 kilocalories per kilo as their adult requirement, actual body weight per day. For patients with BMI 30 to 50 and they are in the intensive care unit, illness and metabolically stressed, they will get between 11 to 14 kilocalories per kilo actual body weight. For illness and metabolic stress or critical care with BMI greater than 50, it's 22 to 25. And if patients have major burn injuries that cover at least 50% of their body or their body surface area, they will need at least 30 kilocalories per kilo. So the easiest way to break down this slide is that normal patients typically need 20 to 30 kilocalories per kilo. Patients who are more metabolically stressed and have normal BMIs or BMIs less than 30, overweight or normal, or underweight, will need 25 to 30, so at the higher range of that normal end. If you have a burn injury, it's higher than that. And if you have patients who are obese, there are alterations there also. Keep in mind that all of these are measured in actual body weight, except for this last one, the BMI greater than 50. In addition, throughout this presentation, we're going to be focused mostly on adult patients. So if you do have a pediatric patient that needs nutrition support, their nutrition requirements are going to be different. But given that this is such a specialized population, we're not going to focus on that for the general purpose of this class today. We also have predictive equations that can be used as an alternative to weight-based equations to actually assess patients. So you see there's many different equation types, and these are just one set of equations: Harris-Benedict, Mifflin-St. Penn State, which are just examples of predictive equations. There are hundreds of different predictive equations out there, though. And what these predictive equations do is they actually take in a parameter or parameters of your patient. So things like height, weight, age, for example. They might even take into account things like ventilator settings and your maximum temperature per day to actually spit out an amount of calories that that patient may need per day. There are some equations that are better for certain populations rather than others. I'm not going to have you know any of these equations specifically for exam purposes. I just want you to know that these exist, and that there may be certain equations that may correlate better to certain types of disease states rather than others. There may be certain equations that are better for critical care patients. There may be equations that are better for neurology patients, for example. There may be equations that are better for gastrointestinal patients or surgery patients. It all depends on the patient population that you're practicing with. So whenever you go out into practice, you may see them use weight-based equations, predictive equations, or indirect calorimetry. Again, the weight-based equations that we talked about on the last slide are going to be the predominant way to go in terms of measuring calorie requirements, but just be aware that some institutions do use these predictive equations also. And they have relatively similar accuracy depending on which patient population that you may have out there. So now we've already talked about assessing a patient's nutritional requirements. Now what we're going to do is we're going to talk about the macronutrients as a whole, and we're going to talk about fluids as well and fluid requirements. So as you know, your macronutrients basically compose of 3 different types: protein, fat, and carbohydrates, also known as amino acids, lipids, and dextrose, respectively. The first one we'll talk about is protein. So whenever we talk about protein, specifically for IV formulations, we have many different IV formulations that we can actually use for the purposes of parenteral nutrition, or TPN, to actually compound that PN back. So some examples of those are aminosin 2, Travasol, Clinosol, freamine, hepatamine, and trophamine. You might be wondering, well, what are the differences between all of these different proteins? So each different protein is made by a different manufacturer, obviously. There are some minor differences in the components of the way that these bags are made. Some of them may have altered levels of acetate and chloride associated with them that might help to buffer the amino acid bag. And as a result of that, that might make each formulation a little bit different. In general, though, clinically, it's not likely to make a significant clinical difference in terms of what IV formulation you have. In a lot of hospitals will only have 1 to 2 proteins actually available for the purposes of prescribing a PN bag, for example. So keep in mind all these names here. They are bolded for a reason. They are bolded because you should know of them and be aware of them and know that they are amino acid or protein sources. So protein in general functions to grow, move, and maintain lean muscle. So anytime you think about muscle, think protein. Proteins also come in the forms of enzymes and hormones. They help in immunity or wound healing, as do some of our other micronutrients that we'll talk about in a little bit. We have gene transcription and translation as a function of proteins. We do have them as function of buffer for acid-base balance. So if you remember your acid-base disorders, these IV formulations of protein and amino acid actually help in regard to the acid-base balance of a patient. And protein actually provides about 4 kilocalories per 1 gram of protein IV-wise. Again, that is bolded there for a reason. You will need to know that, because as we write our PN formulas, these will be things you need to know. In regards to protein requirements, we do have a wide variety of protein requirements that we have for our patients. Typically, estimated daily provision of protein requirements is around 20 to 25% of calories per patient. You do not need to know this range for any exam purpose. This is just to give you an estimation. Some patients may require higher than that, and some patients may require lower than that. I do want you to know, however, the bolded numbers that you see here in this chart here. So depending on the patient type, you will have different protein requirements that will be required for your patient. So in patients who are healthy and less than 60 years old, they require less protein than, say, a patient who is greater than 60 years old or who is critically ill. And remember, the critically ill patients are the ones that basically have the high metabolic illness severity that we discussed on the calorie slides. So a healthy adult less than 60 or equal to 60 years of age only needs about 0.8 to 1 gram per kilo per day of protein. And usually we base protein requirements a lot of times on the actual ideal body weight, whichever is lower. So keep this in mind as you're looking at your body weights, because you need to know how to calculate your ideal body weight using the Divine formula, as you've learned before in previous classes, and use that ideal body weight to then, factor in, should we use ideal body weight for our dosing of our PN, or should we use actual body weight? In patients who are greater than 60, we typically will reserve 1.5 grams per kilo per day for those patients, because around that time their body mass actually starts to diminish a little bit in a lot of patients who are greater than 60. So we actually have a higher requirement for those patients who are greater than 60, 1.5 grams per kilo per day. In critically ill adults who have BMI less than 30, we typically require only about 1.2 to 2 grams per kilo per day for these patients to basically meet their energy expenditure needs. Whenever a patient is critically ill, a lot of times they go through high amounts of inflammatory process that actually burn off lots of calories and lots of protein. So we try to maintain that energy expenditure and that protein expenditure the best we can by feeding more protein. And in patients who are on continuous renal replacement therapy, which is basically 24/7 dialysis, we will give up to 2.5 grams per kilo for those patients, as those patients will actually have protein taken off by the CRRT machine itself, and they might be even more inflammatory than a traditional critical ill patient. So those are the 3 ranges that you need to know here. I also do have the ranges here if you have patients who are critically ill with higher BMIs and for major burn injury. Just keep in mind that those ranges are there. But you do not need to memorize those for the purposes of the exam. The ones that are in bold are the ones you'll need to know. We also have fat as another one of our macronutrients. So we have essential fatty acids and we have non-essential fatty acids. It's important for us to give fat in the diet, because fatty acids are very important for the propagation of cellular membranes, signal transduction pathways, and gene expression. So whenever we're referring to enteral nutrition, we have dietary lipids that actually provide the means for lipids within tube feeding or enteral nutrition. And then we have IV lipid emulsion, also known as ILE, for parenteral nutrition. So some examples of ILE or IV lipid emulsion are products such as intralipid, smoff-lipid, omega-vanclinolipid, propofol, and clovidipine. And propofol and clovidipine are actually medications that you have learned about at some point in your pharmacy education, but these do have fat calories associated with them because they are actually located within fat emulsion. Fat emulsion appears milky white in general. There are some cautions on a lot of these products, particularly products that are egg-based, for patients who have an egg allergy. So you just want to be cautious of that. It's usually very, very rare that these actually happen. And with these egg allergies, the thing to just remember is that it's not necessarily an intolerance to egg. It is more or less like true anaphylaxis from actually eating eggs or certain parts of eggs. So just be aware of that. You probably won't see that very often, but it is important to know. In terms of dietary fat only provides about 9 kilocalories per kilo. 9 kilocalories per gram of dietary fat. So there's only 9 calories per every gram of dietary fat. And for fat emulsion, there's actually 10 kilocalories per gram of fat emulsion. And this actually has to do with the different excipients that are within fat emulsion itself. Fat emulsion actually contains different products such as glycerin that actually contribute to our overall kilocalorie requirement. And because that glycerin is there as an excipient, it actually increases our calories per gram that we have for fat emulsion. Whenever we are referring to fat emulsion comes in different percentages in terms of concentrations. 10% fat emulsion actually contains about 1.1 kilocalories per ml of calories. For 20%, it's 2 kilocalories per ml, and for 30% fat emulsion, it is 3 kilocalories per ml. For propofol, it's similar in regards to the 10% fat emulsion, so it's 1.1 kilocalories per ml. And for clovidipine, it's 2 kilocalories per ml, or similar to 20% fat emulsion. So it's important to know if you're ever provided a milliliter amount of a certain formulation of fat emulsion, or if you're provided a certain milliliter amount of propofol or clovidipine, that you can actually calculate how many calories are provided from those different products. And for example, if a patient is on propofol or clovidipine, remember, these are medications that traditionally are IV and a lot of times given in the intensive care unit, either for sedation for propofol or for a hypertensive crisis for clovidipine. We can actually take that into account whenever we're dosing our PN bags and our other nutrition, like, for example, tube feeding for our patients. In terms of fat requirements, these typically comprise about 10 to 35% of our total calories. There's no real absolute recommendation for the daily provision of enteral fat. For patients that get IV fat emulsion through PN, provision should not exceed 2.5 grams per kilo for non-critically ill patients and no more than 1 gram per kilo per day for critically ill patients. And the reason why we have a lower limit for critically ill patients is that even though these patients tend to be more hypermetabolic, fat emulsion, because it is fat, actually has a higher risk of growing things or predisposition for having different types of microorganisms associated with that, particularly fungus. So whenever we have a critically ill patient, patients are actually more prone to developing these infections, particularly those who are immunosuppressed. So one thing that we want to keep in mind is that we shouldn't give them more than 1 gram per kilo per day for critically ill patients. Typically, the IV infusion rate should be limited to 0.1 grams per kilo per hour. That's not a rate that you need to know. Something that you do need to know that is very, very important in terms of the allocation of fat emulsion is if a patient has a triglyceride level greater than 400 to 500, in those cases, fat emulsion should be held. And the reason why is that we don't want to give patients more fat than what they need, because if we increase that amount of fat that they're getting, or basically keep giving it to them and their triglycerides are elevated, that actually puts them at the risk of developing pancreatitis from hypertriglyceridemia. That's not something that we want. Additionally, if a patient has hemodynamic instability, such as a mean arterial pressure less than 65 or systolic blood pressure less than 90, this means that the patient might be potentially infectious. So they might have sepsis or septic shock. It doesn't necessarily mean a full definitive diagnosis, because the patient just might be hypovolemic or they might have cardiogenic shock. But if a patient has sepsis or septic shock with those parameters meeting hemodynamic instability or a potential infection risk, sometimes fat emulsion can actually be held in these cases as well. This is more seen with soybean oil associated products such as intralipid. The other fat emulsion products such as smofflipid, for example, have less soy base versus intralipid. Intralipid was basically the first fat emulsion product of basically the 4 fat emulsion products we discussed on the previous slide to come out, and has always been a concern because of the soybean oil association with it. Smofflipid has less soybean oil associated with it than intralipid. It actually has soybean oil, MCT oil or medium chain triglyceride oil, olive oil, and fish oil. That's where the term SMOF comes from, SMOF. Soybean oil, MCT, olive oil, fish oil. And SMOF lipid is actually, coming up in usage because of its less risk for infection. Omega-Vin is a product that is made up of basically fish oil, and then clinolipid has its own different profile. So whenever we're looking at fat requirements, additionally, a low provision of fat in the diet may result in essential fatty acid deficiency. This is one of the complications that we can see sometimes from parenteral nutrition specifically. And this will actually resonate as a rash or dermatitis, as well as thinning of the hair, as well as other types of skin irregularities. So, and that is just a result of a lack of essential fatty acids. This typically happens over the course of a couple of weeks, and it's not something that happens, on the very short term. It can be relieved by giving a patient essential fatty acids again, but if we do hold fat emulsion, particularly for 2 weeks or more, we can potentially see essential fatty acid deficiency. Carbohydrates are our last macronutrient. So whenever we think of PN, we typically think of these as provided by dextrose. So we might have anywhere from concentration of D5W all the way up to D70W. D70W meaning that there are 70 grams of dextrose per 100 mLs. And as you know, carbohydrates function in a lot of different ways. If you remember back to your basic biochemistry, they function as a substrate for glycolysis, glycogenesis, ATP production, which is very, very big function of carbohydrates, as well as serum glucose maintenance, which is going to be important whenever we are looking at patients, for example, that have diabetes. Important point about carbohydrates, specifically dextrose, is that they provide 3.4 calories per gram of dextrose. So that number is bolded. That is something you need to know. In terms of dextrose requirements for PN and our total daily provision, for daily provision, dextrose makes up a core amount of our calorie requirements. Generally 45% or more of our total calories. Whenever we are dosing PN, particularly, we want to make sure that we provide at least 150 grams of dextrose per day. And we typically start PN by dosing it lower, such as 150 grams or 2 to 3 grams per kilo on day 1 of PN therapy. So at this point, they might not necessarily be at their nutritional goal. And what we want to do in terms of these patients and why we're actually dosing it so low is we want to prevent a syndrome called refeeding syndrome. So whenever we have a patient who has not been getting a lot of food recently, and that's something that we'll see with a lot of PN patients, is that they will either be malnourished because they haven't eaten or because of their disease process or something other that is going on, or we've held nutrition for them for a certain period of time because PN is a very risky therapy, and as we mentioned before, has a risk of infection. So we want to make sure that if we do need to give a patient nutrition, that the benefit outweighs the risk. So with these patients, if they have not been fed recently, which a lot of PN patients won't have been fed recently, what happens is in the glycolysis pathway, those processes start to ramp up again, versus if you haven't fed someone for a little bit, those processes generally are much slower. And as a result of those processes being much slower, whenever you start feeding someone again, those processes start to ramp up. So whenever those processes start to ramp up, we are actually making more ATP. And whenever we make more ATP, that actually will use up a lot of our different electrolytes, particularly phosphorus. Because remember, in glycolysis, ADP is used to make ATP. And essentially, we need phosphorus from the body to make that ATP. And if we don't have that phosphorus, then in that case, in a certain location, we need to basically take it from somewhere else. And our body has stores of phosphorus in different places. So it will basically drive our levels of phosphorus down in the body, as well as our potassium and our magnesium. And that's how you basically get refeeding syndrome. So it causes a lot of electrolyte disturbances in our body. And to minimize the risk of that, we start feeding dextrose much slower so those processes don't get ramped up as fast. Our daily requirement rarely exceeds 5 milligrams per kilo per minute for dextrose. That's not a number you need to know. And it's usually calculated last when we actually write a PN formula. So whenever we're looking at macronutrients, we actually calculate dextrose last. In terms of fluid requirements are dependent on many different factors. If you have a pediatric or neonatal patient, you might use other formulas such as the Holiday Seeger formula. For adults, there are many different formulas out there to measure fluid requirements. So these can be 30 to 40 mils per kilo, 1 mil per kilocal ingested, or 1,500 mils per meter squared. And you don't need to know any of these numbers for your exam. I would know, though, however, certain cases where you might fluid restrict patients. So patients who have heart failure, patients who have end-stage renal disease, particularly who are on dialysis, like hemodialysis, for example, and patients who are cirrhotic or have end-stage liver disease may require fluid restriction because these patients are more prone to building up fluid. The reason why this is important in PN therapy is that in PN therapy, we're actually determining a certain amount of total volume associated to be given with that PN. And when we have that amount given with that PN, we need to take into account our total fluid requirements, as well as the other medications that contain fluid the patient may be getting. So now we're going to discuss micronutrients. Micronutrients consist of electrolytes, trace elements, as well as vitamins. So in terms of electrolytes, electrolytes are things that you are probably used to seeing because you've seen many different lab panels that are out there, like a BMP or a basic metabolic panel. Electrolytes are basically helping to supplement a lot of the electrolytes, obviously, on your BMP. So in terms of parenteral nutrition, we have a lot of different electrolyte formulations that are out there. For sodium and potassium, we have chloride, acetate, and phosphate salts that we use for dosing PN. For our choice calcium salt for PN, it's calcium gluconate. And for phosphorus, we actually have sodium and potassium phosphate. Now, traditionally, a lot of our electrolytes are dosed in milliequivalents. However, phosphorus is dosed in millimoles. And that's a very important thing to realize because whenever we're looking at total allocation of electrolytes such as sodium and potassium, it's important that we know how to convert between millimoles and milliequivalents for sodium and potassium respectively. For sodium, there are actually basically a large difference between the millimoles and the milliequivalents, and that can actually be converted with a factor of 1.33. And what that means is that for every 1 millimole of sodium phosphate that we have, there are actually 1.33 milliequivalents of sodium. So whenever you do the stoichiometry and the basic chemistry conversion, we actually get that 10 millimoles of sodium phos is actually equivalent to 13.3 milliequivalents of sodium. For potassium, the factor is 1.47. That means that there are 1.47 milliequivalents of potassium for every 1 millimole of potassium phosphate. So 10 times 1.47 is 14.7. Another big thing that's associated in terms of phosphorus and calcium specifically is that calcium and phosphorus actually can precipitate in a PN bag if given in high amounts or if certain other factors in a PN bag are met. So usually what we do with calcium and phosphorus is that we actually will dose phosphorus and calcium in a certain way to not exceed a certain amount in the PN bag. The rule that I traditionally use for this, and this is just a rule that I've learned on my own in practice and doesn't necessarily have any, reputable study or anything like that, is that if you have a combination of the millimoles of phosphorus plus your milliequivalents of calcium, if that exceeds or equals 40 per each liter of PN that you have, you might be likely to precipitate your calcium and phosphorus in those cases. However, what we usually like to do in the cases of calcium and phosphorus is to plot these, what's known as a calcium phosphate curve. And that is basically the gold standard that we use to determine if a patient might precipitate calcium and phos. Additionally, we do have magnesium and chloride salts available as well. Magnesium is magnesium sulfate, and we actually did talk about sodium and potassium chloride above. Going back to calcium and phosphate curves, though, I'll actually show you this on the next slide. So this is actually an example of a calcium phosphate curve. Each calcium phosphate curve actually correlates with a certain amino acid. And whenever you plot the amount of calcium gluconate that's in a PN bag versus the amount of phosphorus concentration or phosphate concentration that we have in a bag in millimoles per liter versus calcium gluconate milliequivalents per liter, we plot those two numbers that are in the PN bag. And if they show up on the left side of this graph, that is considered to be what is considered compatible. Whenever you plot it, if the intersecting lines actually intersect in this incompatibility zone, it means that bag will not be able to be compounded because it's likely to precipitate calcium and phosphate. So there's a few different ways that you can kind of get around this. Usually the best way is to decrease either the calcium that's in the bag or decrease the phosphate that's in the bag. And if you need that additional calcium or phosphate to actually give to the patient, you can still give it to the patient, but you can give it to them as a separate IV infusion that's separate from the PN bag. If you do fall on this line here, that's between the incompatibility and compatibility zones, if you fall on the line, it's more safer to not give the bag, given that if you're on the line, you are at risk. So it's always best to be off of that line whenever you're assessing a calcium phosphate curve. And a lot of times technologies will actually help you graph these. In some cases where you don't have technology available, you may have to graph it yourself. In terms of electrolyte requirements for a PN bag will vary depending on what type of electrolyte you have. So there are standard daily requirements that we have for each electrolyte. For example, for calcium, it's 10 to 15 milliequivalents. For magnesium, it's 8 to 20 milliequivalents. For phosphorus, it might be 20 to 40 millimoles. For sodium and potassium, it might be 1 to 2 milliequivalents per kilo. And for our acetate salts and chloride salts, we usually balance these as needed to maintain acid-base balance. So what that means is that if a patient is very elevated, for example, on their chloride level, then we might not give as much chloride in the bag, or we might not give none at all, or no salts of that type. If a patient is very elevated on their bicarbonate level, or their CO2 level on the basic metabolic panel, we might not give as much acetate, because remember that acetate metabolically actually converts to bicarb in the body. So we might balance these out depending on the patient's specific parameters. Otherwise, if the bicarb and the chloride on the BMP are actually normal, we might give a 50-50 split, or close to a 50-50 split of these salts in the PN bag. Another point to make on this is these are just standard daily requirements. There might be other factors that may increase needs, and there might be other factors that decrease needs of these certain electrolytes in the body. One thing that might decrease needs of certain electrolytes, and one that is very, very common, is renal dysfunction. So if you have a patient with renal dysfunction, sometimes they are not able to actually urinate out the proper amount of electrolytes that they normally would. And as a result, those electrolytes may accumulate in patients. If those electrolytes are accumulating in patients, then in those cases, you might give less than the standard daily requirements that you see here. Or you might give none at all. For example, if a patient has a serum potassium above 5 milliequivalents per liter, which we know is supratherapeutic, we might not give any potassium in that PN bag that day. Or if we expect it to be elevated, we might give 0. Whenever we're looking at electrolyte requirements, these things are not always hard science. Sometimes it is an art. You have to assess basically where the trends are going and how do we think that the patient is actually going to progress in terms of their electrolyte that may be supratherapeutic, subtherapeutic, or if we expect that electrolyte trend might have that electrolyte be within normal limits, we might dose our electrolytes based on those things. And we'll kind of go over this in an exercise whenever we look at PN dosing of electrolytes. We also have trace elements that are common. We have chromium, copper, iron, manganese, selenium, and zinc. Most of these are metals. The only one that is technically not a metal is selenium. With our daily trace element requirements, you see here that each of them has a specific dosing for adult patients. You don't need to know these dosings off the top of your head. The main thing that I would want you to know, though, is iron is typically not included in trace element formulations in America. And part of the reason why we don't routinely include iron as a trace element in PN is that it actually causes the PN bag to what we call crack, particularly if that PN bag contains fat emulsion. So if we have iron in a bag that contains fat emulsion, it actually increases the risk that fat emulsion will actually separate out into its original layers. And remember, emulsion basically means a mixing of 2 or more layers together into one more homogeneous style layer. We don't want those layers to separate because whenever something is in an emulsion, it's meant to be in an emulsion for administration. So except for the formulation known as Atom N, which is a formulation that is popular in Europe and primarily distributed in Europe, except for in times of shortage where we may actually have it in America, we don't usually have iron in trace element formulations. In terms of trace element considerations, we do have a few products that are out there. Those include Trail Mint, which is a new and upcoming formulation, which we typically provide 1 ml in each PN bag. You see that number is bolded there. This formulation aligns best with our adult trace element requirements, and people are typically now using this more than the previous commonly used formulation known as multi-trace concentrate or multi-trace 5, MTE5. Both of these are provided as 1 milliliter if you do have these products available to you in compounding PN at an institution you may work at in the future or do a rotation at. And then we have Atom N, which we addressed earlier, which contains iron. So we do have to be concerned with these trace elements. These are important for us in general to complete certain bodily functions. But if you have hepatic elimination issues, particularly in patients that have cirrhosis, for example, or more or less a T-billy greater than 2 milligrams per deciliter, we always consider reducing trace for these patients and the amount that we give them. And it's not necessarily evidence-driven about how much we should reduce trace for these patients below the 1 milliliter standard that we have for Trail Mint and multi-trace concentrate. For these patients, we may, just give half a milliliter, for example. We might give, 1 milliliter every week. Another standard practice is to give half a milliliter every day as a standard to keep things consistent. But usually we're concerned about the copper and manganese accumulation with these products. A lot of times more so the copper component. Manganese toxicity is very, very rare, but we are concerned with hepatic elimination issues with these products. For renal elimination, which is more so with zinc, selenium, and chromium specifically, it's lesser of a concern because most of the time, if a patient has severe renal insufficiency, a lot of times they're going to be getting dialysis. And remember, about the tenets of dialysis is that these smaller molecules or smaller atoms will be able to be taken off more easily with dialysis than a larger molecule. So zinc, selenium, and chromium, because they're elemental in nature, they will be able to be taken off via dialysis or renal replacement therapy. Vitamins are typically allotted to each parenteral nutrition patient daily, except for in times where we have shortages or if a patient for some reason has hypervitaminosis, which is relatively rare for you to know about. Common IV formulations, the most common one is multivitamin infusion or MVI. MVI 12 and MVI 13. The difference between MVI 12 and MVI 13 is that MVI 13 actually contains phytonadione, which is vitamin K. So if you have a patient who, for example, is on warfarin and is receiving PN with either MVI 12 or MVI 13, it might affect your respective INR levels. We typically give multivitamin infusion as 10 milliliters daily, and these products usually make the PN bag appear yellow. And the way to kind of remember this is if you have a patient who uses alcohol and comes into the hospital, we typically give these patients banana bags. A banana bag is a bag that contains different vitamins as well as electrolytes and fluids. The vitamin formulation is basically a multivitamin formulation, which makes the bag look yellow. So that's actually why banana bags look yellow, is because of multivitamin. Now we're going to discuss enteral nutrition, or what we know as oral feeding and tube feeding. So enteral nutrition is also known as tube feeding. It is the delivery of nutrients via a tube into the gastrointestinal tract. We can also deliver medications that are typically oral medications via this route also, in the event that the patient is not able to swallow on their own. Enteral nutrition or tube feeding typically provides calories and macronutrients in the form of fat, carbs, and protein, as well as micronutrients to our patients, electrolytes, trace elements, and vitamins. We do have many different routes that we can give nutrition via for enteral nutrition. So our typical way of taking in food for a normal patient who is not on tube feeding is to take it in via the mouth. But if we are not able to swallow, or if there are other anatomical reasons for us not to be able to, eat on our own, another big indication for tube feeding is patients who are intubated and sedated. What actually happens in those patients is that whenever a patient is intubated, a lot of times we will drop a tube down their throat, and that will terminate a lot of times in the stomach, an orogastric tube or a nasogastric tube, more commonly a nasogastric tube, for them to basically get nutrients while the patient is intubated. But other reasons for a patient to have enteral nutrition needs or tube feeding needs would be things neurologically that may happen with patients, such as a stroke. So more commonly than not, we do use nasogastric tubes. Nasogastric tube is a tube that goes in through the nose and terminates in the stomach. We also use nasojejunal tubes a lot. Nasojejunal tubes are used when a patient has some type of intolerance, for example, to regular nasogastric feeding. So if they are having lots of abdominal distension and intolerance to nasogastric feeding, like lots of nausea, vomiting, or diarrhea, they may just send that nasogastric tube down a little bit further into the jejunum. Remember that the small intestine is made up of the duodenum, the jejunum, and the ileum. And whenever we have those components, the later that you feed the GI tract, the later that you feed in the GI tract, basically the less that you'll likely have symptoms like nausea and vomiting. But it also, on the flip side, this may affect the digestive processes of certain types of food and nutrients. So we have to keep that into account also. Another way that we can feed patients is through ostomies. Most commonly, a percutaneous endoscopic gastrostomy or a PEG tube, or a percutaneous endoscopic jejunostomy or a PEG tube, PEG or PEJ. And these are also known as G tubes or J tubes. Typically, these are used in patients who need chronic tube feeding support. So usually, we do not keep in nasogastric tubes and nasojejunal tubes typically longer than a couple of weeks. And usually we will only keep these in a couple of weeks because usually a lot of times these patients may not necessarily need it for the whole time. Their illness might resolve after a certain period of time. And another reason why we don't keep them is because these nasogastric and nasojejunal tubes just don't look nice whenever you have a patient who has them, because obviously they are not inconspicuous. They can be seen very easily by anyone that you interact with, and that can obviously cause some, problems for patients socially. So what we actually do a lot of times in our patients who need nutrition long-term for 2 weeks or longer, via tube feeding, is we will actually install a percutaneous endoscopic gastrostomy or a jejunostomy. This is done surgically, so keep in mind that we don't do this immediately for patients. We typically wait because it is a surgical procedure and the patient is put under anesthesia for the installation of these tubes. So we do want to keep that in the back of our mind. These are not first line, and that is the main point I want you to know from this slide, is that usually we go nasogastric first or orogastric sometimes. But percutaneous endoscopic gastrostomy is usually a second to third line option for our patients that need tube feeding. We have many different tube feeding formulas that are out there. The top line is basically the tube feeding that you would see hanging in a room of a patient who is getting tube feeding. We might also feed patients via tube feeding intermittently with cans or smaller bottles that you actually see here. Dietitians are traditionally more responsible for knowing about all the different tube feeding formulas. It's not necessarily something that a pharmacist would always necessarily know about in terms of the selection of a lot of these different products. Just know that these products do contain macronutrients. They contain vitamins, trace elements, and electrolytes. So whenever you have a patient that you're assessing, keep that in mind if they are receiving tube feeding, that they are going to be getting those components in their tube feeding. Tube feeding indications. So tube feeding is typically given to patients who are unable to achieve nutrition via oral diet alone. So whenever we say enteronutrition, we can refer to this as tube feeding, but enteronutrition can also encompass regular oral diet. So just keep that in mind. But for our purposes, most of the time whenever we say enteronutrition, we're going to be referring to tube feeding. So we usually give this to patients who can't take in nutrients on their own, but they do have typically a functional GI tract to get enteronutrition. So some potential indications that we previously mentioned: neurological impairment, so if they're not with it to where they can actually have a meal on their own; intubation, because we can actually descend that tube parallel to the endotracheal tube and to the gut. Other types of organ dysfunction: pancreatitis, anorexia, failure to thrive, which is just basically a state where a patient is doesn't have the willpower or is unable to basically, eat on their own. They might not be able to do their normal activities of daily living on their own. That's more or less what failure to thrive means. You have a narrowing of the esophagus or the intestines, also known as esophageal or intestinal atresia. And we might also give it to other patients who have other hypermetabolic states, such as sepsis, burns, or post-surgery, even if the patient is able to eat on their own. Sometimes the amount of that the patient is actually able to eat on their own doesn't necessarily meet their nutritional needs. So patients may eat very sparingly. They might have like 1 or 2 bites a day. That's not going to make up their nutritional requirements. So if they are able to tolerate enteral nutrition via the GI tract, and again, functional GI tract, hint, star is what you need here. In those cases, we can give tube feeding. So usually, whenever we're looking to see if a patient is eligible for tube feeding, the main factor again is functional GI tract. That's what we want to see to be eligible for tube feeding. When do we start enteral nutrition? So we can actually start enteral nutrition as soon as we can in any types of patients. So it's typically recommended, once you have a patient who might be eligible for enteral nutrition, to start it relatively quickly within 24 to 48 hours if they're going to be put in the hospital. Early delivery of any type of nutrition promotes gut integrity. And gut integrity is very important because our gut is actually one of the main sources of our immunity in the body, other than the skin. Whenever we actually stimulate the gut, we stimulate immunoglobulin A, or IgA, which actually promotes a lot of the different immunological processes in our body. Whenever we start enteral nutrition, even the littlest amount can actually provide that immunological protection, such as 10 to 20 mils per hour continuously. And this is what we know as trickle feeding, trophic feeding, or permissive underfeeding. We actually start patients at that low rate first to see if they're going to be able to tolerate the higher rates. Because if a patient starts to have nausea or vomiting or excessive diarrhea, that formula might not necessarily be the best for them, or they might have some other type of GI issue where we actually need to assess a little bit further. We actually can advance the tube feeding, and a lot of times it's advanced by 10 mils per hour every 48 hours until a caloric goal is reached. And this can be achieved via a rate-based method, or by what we also know as a volume-based method. In some cases, we may have to stop tube feeding throughout the day for certain procedures or certain medication administrations. And volume-based feeding basically provides us a way to basically feed that total amount of volume that we need for our patient. The goal for us is to reach greater than 80% of our caloric goal within 48 to 72 hours. So 2 to 3 days, hopefully we are at goal. And goal basically is the calorie requirements that we determine for our patient. We can also intermittently feed our patients, though we don't do this traditionally with a lot of inpatient patients. We do it in some cases for our outpatients who are able to tolerate it a little bit better, so they don't have to be, continuously on tube feeding 24/7. So a lot of times we'll see feeding given continuously. Intermittent feeds almost kind of mimic normal meals. So you can actually feed them over about 20 to 60 minutes, 4 to 6 times a day. With intermittent feeding, you can do bolus feeds that kind of mimic the typical normal meal cycle. Or you can do what's known as cyclic feeding, which is a period over less than 24 hours. So that might be 16 hours, that might be 12 hours. And oral feeds is tolerated if the patient's able to swallow on their own. You can basically give them a little bit of oral if they're able to swallow. If they're not able to swallow, it's okay for all of their nutrition to be provided by tube feeding. Whenever a patient has hemodynamic instability, such as a low blood pressure, for example, again, MAP less than 65, systolic less than 90, that might not necessarily be the best case to give tube feeding. And the reason why we, kind of shy away from that is whenever you are on vasopressor agents to keep your blood pressure up, usually blood is shunted away from that gut. And when blood is shunted away from the gut, it actually will cause lots of nausea and vomiting to occur because the gut likes blood. The gut likes to receive blood on its exterior end. The gut does not like to have the blood within the stomach per se, like, that in the cases where you have a gastrointestinal bleed. But the gut does like to have blood supplied to it so that we can actually, give it its oxygen supply and whatnot. If the gut has that blood supply, less nausea and vomiting may occur. And in patients who have shock states or basically hypotensive disease states, those patients may not tolerate enteral nutrition as well because the blood is not going to the gut. It's usually probably going more likely to the two important organs of the brain and the heart. So always caution for use of enteral nutrition during hemodynamic instability or use of high-dose vasopressors. We have lots of different complications that can occur from enteral nutrition. So anything that can occur with regular macronutrients can occur with enteral nutrition. So those are things like hyperglycemia, hypertriglyceridemia. Because tube feeding does have fluid associated with it, fluid overload can happen. Because it does touch and go through the GI tract, nausea, vomiting, and diarrhea can happen. Abdominal distension can also happen. Which basically just means a distending of the abdomen or a stretching of the abdomen, which may not necessarily be comfortable. If you pump too much food into the gut, a patient may be at risk for aspiration or aspiration pneumonia. And what that basically means is that the gut contents are more or less vomited up. And if a patient is not able to control their swallowing reflex, what can happen is that those contents can actually go back down, but they will go down the different tube and go into the lungs. And that's actually how you can aspirate. As humans, we actually aspirate a lot. You've probably gotten into a situation where you swallowed something down the wrong pipe. Aspiration is relatively normal. Aspiration pneumonia, because our gut does have lots of different organisms and bacteria that colonize the gut, can actually occur from aspiration and from tube feeding. So we have to make sure that our patients are going to be at low risk of aspiration. Infection can also occur from enteral nutrition. This is typically associated a lot of times with the placement of the feeding tubes, a lot of times more so with surgical sites like PEG tubes where they are inserted in the stomach, but they can also occur through the insertion of the nose. If that area becomes infected. Anytime that we feed with dextrose or carbohydrates, we are putting a patient at the risk of refeeding syndrome. And typically it's mostly seen in malnourished patients who begin feeding. So again, the ramping up in that glycolysis process. And we typically can see hypophosphatemia from the pulling of phos into the glycolysis cycle and the other cycles to be used for ATP production. So we see hypophosphatemia, but we can also see hypokalemia and hypomagnesemia. They don't always present together as all three. You might only see one of these, but hypophosphatemia is the most common. We do have mechanical complications that can occur from enteral nutrition. These include tube occlusion, which is an improper medication administration. So it's very important that we always, anytime we give medications down a feeding tube, if a patient can't swallow medications on their own, that we flush the feeding tube before and after the medication is given. So we want to make sure that tube is clean first, basically break down the medication, crush the medication beforehand if it is a crushable medication, dissolve it in water or normal saline, and then basically put it down the feeding tube and then flush the tube again. The tube may also be malpositioned, so this can result from placing the tube in the wrong position or pulling the feeding tube while inserted. So if a patient is agitated, they might actually pull their tube out. That actually happens very commonly. We don't want the tube in the wrong position because we want it to be obviously in the gut. But if it goes down the wrong tube and it goes into the lungs, if we don't check the placement of it first with, for example, an X-ray, we might actually, nasal pulmonarily intubate a patient. And if we start feeding that patient into the lungs, it can actually be fatal to the patient and cause them more or less to drown within their own bodies. And we don't want that to happen. we usually want to confirm the placement with a chest x-ray. And there are some new technologies out there where you might not necessarily have to have a chest x-ray to confirm, but I'll tell you most hospitals still confirm placement with a chest x-ray. Again, it's important to flush a feeding tube before and after medication administration with 15 to 30 mils of water or normal saline to make sure that that tube is clean and patent for use. Anytime that the tube closes in, it's not necessarily a good thing. And if that tube closes in, it's not going to be able to be used if it's clogged. We don't want to flush the feeding tube with cola or juices because that can actually result in the tube becoming very sticky. And if the tube becomes sticky, we might not be able to flush anything down that tube. Think about basically, if you get something stuck in a straw, for example. Think of one common thing that, a lot of people drink is boba tea. If you get one of those little boba stuck in the straw and you're not able to get the boba out, you're not going to be able to actually flush anything down that straw, or you're not actually going to be able to get a lot of actual fluid into the straw for administration to yourself. Same concept goes with a feeding tube. Medication delivery is something that's very important for pharmacists to be aware about whenever you have a patient who has a feeding tube that needs medications. So certain oral medications may be administered through feeding tubes after crushing and mixing these medications in 15 to 30 mils of water or normal saline. And usually we do prefer solutions and suspensions for administration because these are much easier to prepare because you don't have to crush different solid medication dosage forms. Most medications are fine to administer via a feeding tube, but obviously you'll have to refer to the manufacturer's package insert a lot of times to see if you can crush medications reliably, or ISMP's do not crush list, which we'll talk about shortly. Medications that should never be administered via feeding tube. Anything that is ultra release. So if the medication is sustained release, delayed release, or extended release, so SR, DR, XR, CR, whatever R that you can basically think of other than IR, immediate release. Those medications typically are not meant to be crushed because that can obviously affect the pharmacokinetics of the drug, the bioavailability of drug, and cause problems to happen. We don't want to give sublingual medications down the feeding tube because those are also meant for absorption in certain places, for example, in the oral mucosa. So things like nitroglycerin sublingual tablet would not be suitable for administration. You could get away with doing things like nitroglycerin spray if able to be administered, or even nitroglycerin paste or ointment that can be rubbed on the chest in cases where patients have chest pain actively. We don't want to put down the feeding tube enteric-coated tablets, the most common one being aspirin. If we do have the need to use aspirin and put aspirin down a feeding tube, we can actually change that to the chewable formulation. Yes, the enteric-coated formulation does provide better protection against GI-related side effects, but if you have to administer the medication, you have to administer the medication. And chewable aspirin, while it may not be as ideal for the GI side effects, is more preferable for administration through a feeding tube. There are other special medications that should not be crushed ever and put down feeding tubes. Dabigatran is one of them. Dabigatran's bioavailability actually increases by up to 50% whenever you crush it, and that can put the patient at risk of a bleed. Benzonatate or Tessalon pearls, which are used for cough, should not be crushed because these actually release a certain anesthetic from within the agent that can numb the throat and actually increase the frequency of cough. Another medication that's not listed on here is ciprofloxacin suspension. This can actually cause the feeding tube to clog, and that's another special one that you may see in practice. There are potential drug-nutrient interactions with enteral nutrition also. So even though they do have these interactions, you can still give these medications through the feeding tube if certain precautions are basically taken into account. For things like phenytoin, which may have reduced bioavailability with tube feeding, you can still give it if tube feeding is held 1 to 2 hours before and after phenytoin administration. You can also alternatively convert phenytoin to an IV formulation if needed. Fluoroquinolines and tetracyclines, because they do bind with di and trivalent cations like calcium, for example, we may hold tube feeding 1 hour before and after administration. With warfarin, there is also a decreased absorption issue. We can still give the warfarin, but we might just have to adjust the dose based on the INR level. ISMP does have a do not crush list that is out there. So it does list basically all of the medications that are out there that should not be crushed. The ISMP is the Institute for Safe Medication Practices. So they publish this list as well as provide other safety recommendations in regards to medications in general. And this list will provide the dosage form that is not, or basically the dosage form that should not be given via tube feeding and the reason why it should not be crushed. Now we are going to talk about parenteral nutrition. So whenever we are talking about parenteral nutrition, we're actually looking in terms of this slide at the right side of this diagram. So if a patient does not have a functional GI tract, a patient may be eligible for the allocation of parenteral nutrition. So parenteral nutrition, or PN therapy, is also known as TPN or TNA. TNA is total nutrient admixture. TPN is total parenteral nutrition. TPN is all-encompassing of all parenteral nutrition. You might hear people say that. Total nutrient admixture, which is another term you might hear in some areas, is typically considered a 3-in-1 formulation for the most part, but that's just an FYI. I don't necessarily require you to know that because most people will still refer to parenteral nutrition as PN or TPN. I personally prefer PN. Delivery of nutrients via IV line into the systemic circulation is basically what parenteral nutrition is, and we can do this via 2 different line methods: peripheral parenteral nutrition or central parenteral nutrition, which are basically exactly what they sound like. Peripheral being administered by a peripheral line, and central being administered by a central line. So peripheral parenteral nutrition is also known as PPN. So it's the delivery of nutrients via peripheral IV line. Alternatively, another line called a midline into systemic circulation. A lot of times whenever we give peripheral parenteral nutrition, we're giving it for a very, very short time. And the reason why is that peripheral parenteral nutrition is actually limited in terms of the osmolarity that we can actually give to our patients, which is a product of our macronutrients and mainly our electrolytes that we are giving. We cannot give more than 900 milliosmoles per liter due to risk of vein irritation and basically bursting veins. Because whenever we give something in a peripheral vein, if it has a high osmolarity or osmolality, or what we also consider a high tonicity, it will irritate veins and it will basically cause veins to become inflamed and burst. And that's what thrombophlebitis essentially means, vein irritation. So we usually will give peripheral parenteral nutrition when we don't have a central line, is basically what I want you to get from here. And another thing is that because of this osmolarity limit, usually if you need to give patients their full nutritional requirements, you're having to give many, many liters of fluid to these patients because it is so diluted. If you are giving about 2,000 milliliters of peripheral parenteral nutrition, a lot of times that will not provide more than typically around 800 to 1,000 calories per day, which my former or my mentor for nutrition support actually has compared to basically a few Snickers bars, if you actually think about it. whenever you think about the amount of food that you're giving patients, it's not really adequate to give a lot of patients 800 to 1,000 calories per day. It's more appropriate to give them, a lot of times more than 1,000 calories a day from most of the patients that you'll see, particularly adult patients. So these are examples of peripheral lines. So you see here that they are, injected at different sites in the periphery. So these can be in your hand that you see here. And what is done is that they will insert a needle here in the hand, and then they will basically, put the cannula in at the same time, tape it down and take the needle out. And then you basically have a little cannula that is resting there. So that you can attach an IV line to. And these concepts will basically, trickle down into your IV administration of any IV medications also. You also have the type where they're, not just in the hand, but they may be in the forearm. It really depends on where that line is going to terminate. And a lot of times with these lines, they are just basically the cannula that's there, so they're not really going anywhere. You also have other types of catheters that are placed in patients for more longer term. One of the examples here is a midline catheter, or a midline, as we mentioned on the previous slide. This midline here is actually not just a cannula, but it will actually be threaded into a peripheral vein that you see here on the arm, and then threaded up to a point before it actually reaches the superior vena cava, or the right atrial junction in the heart. That is what makes it a midline. Basically, a midline is basically somewhere between where it is inserted and the superior vena cava, but it doesn't reach the superior vena cava, which is very important to know. So like we mentioned earlier, the osmolarity of the PPN components is going to dictate how much macronutrient or electrolyte you can actually put into the PPN. And these are basically the osmolarities per gram of each of these different components. A lot of times, a lot of computer softwares will actually do the calculation for you. I'm not going to require you to know the calculations in this class for that, but I will just expect that you have a knowledge of where to find this information if you ever need it. Usually, one thing to know is that fat emulsion is relatively benign whenever we are considering PPN osmolarity. And that's important to know because we can still administer fat via our peripheral line with an appropriate filter. Central parenteral nutrition is a bit different. So the way that central parenteral nutrition differs from peripheral is that central parenteral nutrition, the line is terminating in the superior vena cava, or where the right atrial junction is. So central parenteral nutrition is also known as CPN. So we're giving the nutrients via a central IV line into systemic circulation, and this is our preferred route. Anytime that we have a patient who is not getting any other types of nutrition via oral or enteral modality, we will usually want to start central parenteral nutrition on them. But it does have the limitation in that obviously you need a central line for that, and these lines have to actually be placed by skilled healthcare providers. Many a time by a physician, but you might also have other specially trained nurses who can actually put these lines in, because the tip of that line actually has to terminate in the superior vena cava. We usually use PN whenever it's going to be expected that the patient is not going to be able to tolerate PO intake for a while in any form or fashion, whether that be, poor GI tract. In some cases, we might also have other, events where we might have patients on non-invasive respiratory modalities, particularly right now with COVID, such as high flow nasal cannula or BiPAP, where patients might not want to eat, or if they basically get taken off of their BiPAP or their high flow nasal cannula machines for too long, they might need to get intubated. And in those cases, we might also consider central parenteral nutrition for those patients as well. We have many different ways that we can give CPN or central parenteral nutrition. The lines that you will need to know or be familiar with are subclavian, internal jugular, femoral, peripherally inserted central catheter, and implanted port. And again, because central parenteral nutrition is in the superior vena cava or terminating in the superior vena cava, which is our largest venous return in the body. As a result of that, it's very diluted for any type of medication or any other substance that is basically injected into the superior vena cava. And as a result of that large amount of dilution, we can actually give any amount of nutrition that we would like to a patient who's getting CPN. So we can give them their full nutritional requirements if you have a central line. Again, if you have a peripheral line, typically you won't be able to get more than 800 to 1,000 calories reliably without giving too much excessive fluid. So these are the lines that we had mentioned just now. So you have different, core veins or different large bore veins that you have in your body where we can actually insert central lines at. So one of those common ones is the internal jugular, which is found in the neck that you see here. A line can be placed there. A line can also be placed in the chest, which is a subclavian. One of the more longer term lines is called a peripherally inserted central catheter. So this is inserted like it is almost like a midline. However, unlike a midline, you actually will have that line terminate in the superior vena cava right atrial junction. You also have another line called a femoral line. A lot of times, and this is just an FYI, a lot of times a femoral line is not a preferred route if you can get an IJ or an internal jugular, a subclavian, or a PIC. Femoral, we usually go with usually last line because it's not as comfortable for the patient if they have a line in their leg, but it is still effective. And keep in mind that all of these IV lines are basically routed up to the patient into the superior vena cava where it will terminate. And another important part about these central lines, as well as nasogastric tubes and other types of feeding tubes, is that the confirmation of the placement of that line has to be confirmed before you use it. And the way that we do that typically is via X-ray. A lot of times X-ray will be used in practice to confirm the placement of lines or feeding tubes. For feeding tubes specifically, there are some newer technologies that you might not necessarily need a chest X-ray for to confirm that placement, but a lot of hospitals will lay on the side of caution and still confirm them with a chest X-ray. And the radiologist or doctor who is basically reading that chest X-ray will be able to confirm in their chest X-ray report where the tip of that line is and if that line actually needs to be adjusted. And sometimes it may need to be adjusted a few centimeters. Sometimes it actually may be, in a completely incorrect place. And if it is in a completely incorrect place, such as, our lungs, for example, infusing, lots of nutrition directly into the lungs can be a problem that can result in mortality. Another type of central line that is common, particularly with chemotherapy patients, are implanted ports. And these are more chronic IV access that you might see with particularly oncology or chemotherapy patients. Same concept basically goes here in that the line terminates in the superior vena cava or the right atrial junction. And this port is basically placed under the skin. The needle basically will get inserted into the port. And basically from there, that is basically where medication or nutrition can be delivered. They are also known sometimes as portacasts. What are our indications for parenteral nutrition? So the main concept that I want you to understand from this slide, hint, hint, star, star, is that parenteral nutrition is typically given to patients who do not have a functional GI tract. That is the main indication of why we have parenteral nutrition. There are some cases where we can only give a certain amount of nutrition with enteral nutrition. that might not meet a patient's, nutritional requirements. And in those cases, we can give what is called supplementary parenteral nutrition. Though this is not given very often, we do give it to patients sometimes who cannot meet their needs via the GI tract traditionally. But the main thing is that if you do not have a functional GI tract, you may be a candidate for parenteral nutrition. So what are some of those potential indications of why? If you have a small bowel resection, so patients who have different types of infections of the intra-abdominal area, depending on the extent of the bowel infection, that bowel might become gangrenous from a lack of oxygen being supplied to that area, particularly if you're in sepsis or septic shock. And that actually might require a patient to receive a small bowel resection. Other cases where you might get a small bowel resection are things like trauma, for example, if that bowel is severely damaged. Small bowel resection can actually lead to a syndrome called short bowel syndrome. And this is where a patient may not have necessarily the same type of small intestine anatomy and large intestine anatomy to be able to successfully facilitate the feeding of the full amount of enteral nutrition. So usually whenever you get a small bowel resection, a lot of patients will have to re-equilibrate to basically eating again if they are able to eat. And a lot of times our bowels are pretty good at that, depending on how much of the bowel is remaining. And we'll talk about that more whenever we talk about GI surgeries later in the course. But small bowel resections, short bowel syndrome are potential indications. Ileus is another indication, and this is not necessarily ileum, which is the area of the small intestine that refers to ileum. This is ileus. It's basically a slowing of the bowel to basically not moving, or basically little or no peristalsis. And this can result through a variety of different ways. Most commonly, ileus may be seen after surgery, particularly bowel surgeries where a patient may have had their bowel operated on and their bowel is kind of in shock, and as a result, ileus might result. We also might see ileus from patients who are prolonged in bed. So if they're in bed for days or weeks at a time and they're not able to walk adequately or move around adequately, they may develop significant constipation and eventually ileus. Another reason patients might be on or may have ileus is because of opioid therapy. Remember, opioids cause constipation, and whenever you are constipated and are not able to go to the bathroom properly, you might be able to collect a large amount of stool that is there. And sometimes whenever you get too much stool and too much opioids, you actually might develop an ileus. Intractable nausea, vomiting, and diarrhea if on enteral nutrition. We don't want to give those patients enteral nutrition anymore if they have nausea, vomiting, or diarrhea, except for certain cases like pancreatitis, which we'll talk about later on in the course. Bowel obstruction, which is basically a clogging of the bowel in some way. You might also hear these termed small bowel obstructions, or SBOs. Basically, it is a clog in the GI tract where something cannot pass through. GI fistulae or fistula, that is referring to a disconnection where there may be a leakage in your GI tract that may result in the leaking of nutritional contents out of the GI tract. Volvulus is another one where we might have twisting of the intestines, for example, which you actually see here on this scan on the right. This large mass here is actually a lot of twisted intestine that you see here. And when intestines are twisted, that can actually be a medical emergency that needs to be rectified via emergency surgery. Because when you twist the intestine, not only do you not get things through, but you also are not able to deliver oxygen to that intestine. And that is a reason why a bowel may become ischemic, and you might actually get things like small or large bowel resections. Chyleek or chylothorax or chylocystis, these result a lot of times when you have a nick or a hole in your lymphatic system. Your lymphatic system is a very silent system throughout the body, where you basically have a lot of your immunological mediators floating around, but you also have nutritional components floating around. And what happens is sometimes the lymphatic system can be nicked by certain types of cancer, certain types of surgery like cardiothoracic surgery, anything that is involving the thorax or the chest. If a surgeon unknowingly nicks the lymphatic system, which is very hard, to even see, in those cases, you might get a leaking of what is called chyle, or basically a fluid called chyle that actually contains a lot of nutritional components that can basically nutritionally compromise a patient. And if you feed patients via the gut this way, it can actually leak out, which is not going to be the greatest thing. That's why we give these patients a lot of times PN or other formulas that may be compatible with chyle leak. Severe pancreatitis, if they are not a candidate for enteral nutrition, we'll talk about this later on in the course. Cancer, if the patient is not a candidate for enteral nutrition, particularly those who are like, severely nauseated and vomiting, a lot of times are going to be the cases that we see here. And then Crohn's disease, ulcerative colitis, if not a candidate for enteral nutrition, especially Crohn's disease and ulcerative colitis, that is more diffuse. There are lots of Crohn's disease and ulcerative colitis patients that can tolerate normal oral feeding or enteral feeding. It's only if it progresses to the point where they're not able to take it in. Then in those cases, they can get parenteral nutrition. What are the parenteral nutrition components? We talked about a few of these already. So we talked about protein, dextrose, and lipids. The one point that I want to make with parenteral nutrition with lipids is that it's typically can be mixed with other PN components, and we call that a 3-in-1 formulation, where the dextrose, amino acids, and lipids are mixed together in one bag. Those actually require a special 1.2 micron filter to filter out possible bacteria, other particulate matter, and other things that may result from mixing. Anytime that you have fat emulsion, it is typically going to require at minimum a 1.2 micron filter, so keep that in mind. If we have patients who get PN in a 2-in-1 formulation, that is usually the dextrose and amino acid together in one bag. And whenever we're saying dextrose amino acid, we also are including all the typical micronutrients there, also the electrolytes. The same thing goes with 3-in-1. If you have 3-in-1, all the components are in one bag. If we have a 2-in-1, it's dextrose amino acids, electrolytes, vitamins, and trace elements. The vitamins and trace elements are not shown in this little picture. And then we have a separate bag for lipids that is basically transfused on its own. The thing to keep in mind here is that there's not necessarily a clinical reason why you would pick a 3-in-1 over a 2-in-1 particularly. Sometimes it might be out of convenience in regards to the amount of lines that you have. A 3-in-1 is convenient in the case that it actually will all get infused in one line. 2-in-1s require 2 lines, but may be a little bit on the cheaper side because you're only infusing one type of fat emulsion bag, which is typically a 50-gram bag for adults. With the 2-in-1s, though, you do have to take and use 2 types of filters. You have to use a 0.22 micron filter for the 2-in-1 formulation. The way to remember this is 2-2 and 2, 2-in-1, 2-2 micron filter. For the fat emulsion, you still need a 1.2 micron filter. A lot of times at hospitals, you will do one or the other, depending on what your hospital and your institution guidelines provide for. So it will either be 3-in-1 for all patients or 2-in-1 for all patients. Except for obviously patients who do not get fat emulsion because it has to be held. In those cases, those are automatically 2-in-1s. So these have micronutrients in them, as we mentioned before. We also may have other medications that are included in the PN bags. One of them is regular insulin, which we can give starting at a dosage of 10 units per 100 grams of dextrose, particularly in patients who already are predisposed to hyperglycemia or have diabetes. That's usually the patients that we put regular insulin in the bag for. And this is very art-based because you might actually additionally provide basal insulin to these patients in the form of insulin detamir, insulin glargine, or insulin degludec, depending on what you have available on your formulary. We also have other medications that we can give. We can give proton pump inhibitors or H2 blockers in IV formulations as a convenience to put in these bags. It is important to note that if you do have one of these formulations in your PN bag, that you should not be giving a separate medication or a formulation via IV push or IV intermittent infusion. So you shouldn't be giving them, an oral PPI and IV PPI on the side. You should only be giving one agent most of the time. We also have pre-mixed parenteral nutrition. So a lot of times parenteral nutrition is compounded based on individual needs, but we also have pre-mixed parenteral nutrition, which can also meet the needs of a majority of patients, but it might not necessarily meet the needs of all patients. So this can be used as an alternative to custom prescribed PN. Some hospitals have gone completely the route of using pre-mixed parenteral nutrition for convenience purposes. Clinomix is the main type of premixed parenteral nutrition that exists. I just want you to know of its existence and that it can contain amino acids plus dextrose with or without electrolytes. So they have different formulations that are out there. They have Clinomix and Clinomix E. Clinomix E is the one that has electrolytes in the bag. You also have to add in you may add in electrolytes separately. You may also even add multivitamin and trace elements separately into these bags, assuming compatibility. They do have many different concentrations that are out there. These concentrations are referring to the dextrose and protein concentration. The first number that you'll see here is the protein concentration on each of these concentrations. You do not need to know these for your exam purposes. I just want you to know that if you ever see these in practice, the first number is protein or amino acid concentration, and that is basically for example, for this first CPN concentration of 4.25 and 10, that is going to be 4.25% amino acid, which is basically 4.25 grams of amino acid per 100 mLs of solution, over 10% dextrose, which is 10% dextrose, or 10 grams per 100 mils of dextrose. So if you have a liter bag, obviously you would multiply these numbers by 10 and get your resulting formula. With these formulations, you can infuse lipids separately. There is another product called procalamine. Whenever I did my research on this product recently, it was recently discontinued, but I have seen it in practice used as a premixed PPN formulation. There are premixed Clinomix formulations that also meet this build also, that you see the concentrations for here. These concentrations basically for the PPN concentrations here don't exceed the 900 milliosmoles per liter that we learned about earlier. When do we start parenteral nutrition? So PN should only be initiated if EN is contraindicated, or in the cases where EN is not providing enough nutrition to the patient, and if a patient has been in PO for 7 days. So you're like, Dr. Broussard, why are we starving our patients? What really we're looking for is to minimize the risk that we have associated with PN. One of the big complications of PN is infection, and a lot of times those infections will happen as a result of having a central line. Anytime that you have something new that is basically in your patient, like a line, you increase the patient's risk of infection. The same can be said for fat emulsion, which you see here in this right bag here. This bag here looks like a 3-in-1 bag, where they have all of the components of the PN in the actual bag, including the fat emulsion. And fat emulsion, as we mentioned before, leads to increased fungus or fungemia risk, blood infection with fungus involved. So we typically don't want to give our patients PN unless they've been in PO for 7 days, assuming that they're actually well nourished. Now, if your patient is malnourished, which we talked about in the first class of this course, and they do not qualify for EN, in those cases we give them PN immediately, because the data has shown that there is basically benefit to giving PN immediately versus waiting. Remember that nutrition is our baseline and that we want to basically provide nutrition to patients who obviously need it. So if they are malnourished, we need to feed them immediately. A lot of times this will happen usually within 24 to 48 hours of a hospital stay, most of the time 24 hours, but it depends on your hospital and the ability of your hospital to be able to assess those patients. So remember your typical malnutrition criteria. There are many things that can, basically predispose a patient to malnutrition, but some of the key ones are BMI less than 18, reduced energy intake that meets the criteria that you see here, or significant weight loss, particularly weight loss that is unintended. So if you have any of these things in addition to other factors, to basically be considered malnourished, in those cases, we give PN immediately. We do not wait. For EN purposes, we usually can start feeding the gut as soon as it's feasible to feed the gut, which is usually pretty quickly. But for PN, we want to wait to minimize that risk of infection and other complications. What are those other complications, you may ask, other than infection that we mentioned with the addition of a central line? We might have improper catheter positioning, which we mentioned that we're always going to confirm with a chest x-ray. We have hyperglycemia and hypertriglyceridemia, which are similar to internal nutrition. We have infection risk, which we mentioned is a result of the fat emulsion, fungemia risk, as well as the central line being in a patient. There's much more risk of a central line infection as a result of a central line than there is a peripheral line infection, being a result of a peripheral line. These lines are constantly checked by nurses every day whenever you have a patient in the hospital, but because that central line actually has needles and other things that terminate within the patient, that's obviously a problem. A lot of times the peripheral lines, as we see, except for the midline, will just basically have that more or less that little small little port at the end of the patient, and that will the fact that there's no needle there will minimize risk of infection, but it doesn't mean that it's not completely minimized. Refeeding syndrome: anytime you feed someone who is malnourished, and anybody that you feed basically with parenteral nutrition is probably going to be malnourished because they've been in PO for 7 days, or they have already been malnourished. You may see refeeding syndrome with those patients. PN-associated liver disease is typically seen from chronic administration of PN therapy, particularly for PN therapy that's been given for months or weeks at a time. And usually this is as a result because the liver is constantly having to metabolize all of the nutrients that are being fed to the patient, because they are being directly fed through IV 24/7. What we do for those patients sometimes is after about 4 weeks or 28 days or about a month, we will actually consider cycling the patient down. And what that means is instead of giving the PN over 24 hours, we're actually going to give it over a less period of time, like 20 hours, 16 hours, or even all the way down to 12 hours if the patient is really stable. This provides patient time to be off of PN and provides them the ability to basically be a little bit more mobile if they are able to be mobile and not have to carry a PN around with them. A lot of times we cycle in the night times, particularly for patients who are outpatient who need PN therapy, so that they can go about their normal activities during the day. Essential fatty acid deficiency can happen with PN. Keep in mind that a lot of our enteral nutrition formulas do include dietary or enteral fat in them, and as a result we do get our fatty acids from those with enteral nutrition. But with parenteral nutrition we have the option to hold fat, particularly if our triglycerides are elevated or if we have hemodynamic instability. So as a result, if you hold fat emulsion, a lot of times for greater than 2 weeks, we might start seeing signs of essential fatty acid deficiency: dermatitis, rashes, hair thinning, hair loss. And that's something that you don't want a patient to experience. And that's why there are recommendations that typically say within 7 to 10 days of starting parenteral nutrition, you should give them fat, because at that point, the benefits outweigh the risk. You also may see metabolic bone disease as a result of PN therapy, and this is related to varying amounts of not only contamination, but varying amounts of calcium and vitamin D that may be provided to patients via PN therapy. Multivitamin doesn't always necessarily provide the highest amount of vitamin D, depending on the multivitamin formulation that you have available. So, in terms of weeks or months, or basically patients who require a chronic PN, we see metabolic bone disease mostly in those patients. We won't see it acutely. So keep in mind from this slide that a lot of the bottom complications are chronic in nature. Keep in mind the top ones are going to be more acute in nature. So PN-associated liver disease, essential fatty acid deficiency, and metabolic bone disease are long-term or chronic complications from patients who are on PN for weeks or months at a time. These are just some examples of the types of labs that you can monitor for PN therapy. I'm not going to expect you to know this list. This is actually a good, reference that your textbook Piro actually provides in terms of what you have to monitor regularly. Usually at baseline, we typically will monitor weight, vital signs, serum electrolytes, glucose, albumin. We might monitor LFTs and renal function, fluid balance. And we might get serial readings of each of these labs and other diagnostics periodically while the patient is on parenteral nutrition. A lot of times we'll get, electrolytes daily while they're in the hospital. Whenever a patient is, chronically on PN, for example, they might get their labs drawn every week until they're stable, and then it might go to once a month. This is a sample PN order form. We'll also have our own sample PN order form that we'll be using in this class, so stay tuned for that. There are many different specialized populations that we can take into account whenever we are going to give a patient nutrition support. And each of these different specialized populations may have different considerations in regards to macronutrient goals, including protein goals, like in grams per kilo, calorie goals in kilocalories per kilo, as well as different electrolyte goals depending on each of the different patient populations. So end-stage renal disease, including hemodialysis and CRT, is a big specialized population that is common in a lot of different patients, and that can affect our protein and calorie goals sometimes. Cirrhosis or end-stage liver disease, critically ill patients, as we've kind of discussed throughout this talk, oncology patients, pediatric patients, surgical patients, gastrointestinal patients, and home care patients. So just keep in mind that, today's talk is more generalized for the generalized population, but there are also many different specialized populations that are out there. And here are the references for the talk today. We're going to go back to the case. We have a 42-year-old male coming into the ED with sepsis as a result of pneumonia. He was intubated and transferred to the intensive care unit. A central line and a nasogastric tube were placed in the ICU. He currently has a functional GI tract and is not on vasopressor therapy. So case question 1, what are the patient's calorie requirements? The answer here is going to be 25 to 30 kilocalories per kilo. Actual body weight per day. And keep in mind, the reason why it's 25 to 30 is because this patient is critically ill in the intensive care unit. So they have an elevated metabolic stress or illness burden versus a normal patient or a patient with minimal illness burden who is not in the intensive care unit or not critically ill. If they were not critically ill, they can basically be in the range of 20 to 30. They have severe burns, for example, they could be in the range of greater than 30. The next question is, what type of nutrition is most appropriate for the patient to receive? So the answer here is enteral nutrition, or EN. So this patient was intubated, so they are not able to actually take in oral nutrition. And because the GI tract is functional, we actually don't need parenteral nutrition. So parenteral nutrition by the peripheral route or the central route is not indicated if you have a functional GI tract. So enteral nutrition or tube feeding is the best answer for this patient. Case question 3. What's the most likely complication of the type of feeding you selected in case question 2? So remember we picked enteral nutrition. So enteral nutrition can cause abdominal distension. So anything with the gut, if you're feeding the gut, complications from the gut can occur. So those include nausea, vomiting, diarrhea, abdominal distension. In addition, aspiration or aspiration pneumonia can also occur from tube feeding specifically. Whenever we compare that to parenteral nutrition, the same things that can happen between parenteral nutrition and enteral nutrition are things that are related to the macronutrients. So hypertriglyceridemia, hyperglycemia, refeeding syndrome can happen either which way. An infection can happen either which way because an infection can happen with the central line, an infection can happen with phanemotion with parenteral nutrition, or an infection can happen related to the site of the feeding tube for tube feeding or enteral nutrition. Hypokalemia can happen as a result of refeeding syndrome, but because this patient is well nourished, it's not as likely to happen. It can happen, but it's not the most likely complication. Abdominal distension is more likely to happen. Metabolic bone disease is something that happens over the period of weeks to months. And if we are basically giving patient feeding, it's not as likely to happen unless this patient is on chronic PN therapy, for example, and they're not getting the sufficient amount of calcium or vitamin D that they might need in their diet. PN-associated liver disease, it's obviously not it because this is associated with parenteral nutrition administration and typically over the course of weeks. And whenever we have parenteral nutrition-associated liver disease, we actually try to cycle these patients. So we might preemptively start cycling these patients or giving patients shorter-term parenteral nutrition infusions over anywhere between 12 to 16 hours, for the most part, or 18 hours, for example, daily to give that liver a rest. That is all we have today for nutrition support. If you have any questions, please feel free to ask. Thank you and have a great day.